The next paper is by Dr. Arvind Kamajit. He's going to tell us about the outcomes of patients who had neoadjuvant chemotherapy at Groote
Good afternoon, everyone. Thank you very much for having me here. I'm Dr. Kamajit from Groote Hospital, and my talk today will be about the pathological response to neoadjuvant chemotherapy for breast cancer at a single tertiary center with no access to trastuzumab. As mentioned earlier, this will be Groote Hospital, and we do not have access to trastuzumab in the province. So I'd like to thank the UCT Faculty Research Committee for having contributed to the cost of the BIGOSA conference and for allowing me to come here. I'd like to thank Dr. Francois Malherbe for his invaluable support and guidance throughout the study. So as we all know, breast cancer, it's the most commonly diagnosed cancer in South Africa, according to Cancer Stats South Africa, making it a pressing public health issue. Our objective as surgeons is to increase the overall survival of patients, and one of the means to do so is neoadjuvant chemotherapy. Just to rehash a little bit of knowledge, NACT has been used traditionally in resectable cancer, inflammatory breast cancer, and locally advanced breast cancers. We're now using it to downsize tumors so we can actually achieve breast-conserving surgery and to move from more invasive axillary surgery to sentinel lymph node biopsy. The response to neoadjuvant chemotherapy, and particularly the complete pathological response, is a very strong prognostication marker and correlates to overall survival. The aim of this study, it was to determine the response of our patient to neoadjuvant chemotherapy. We also wanted to compare the response of HER2-positive patients to the literature, looking at the possible added effects of trastuzumab to our patients and which patients might benefit from this treatment. So what we did, we collected data for all our breast cancer patients who had surgical resection from the 1st of January 2017 to the 31st of December 2018. We collected the demographics of the patients, and the tumor biology data was obtained from NHLS. The tumor size pre-treatment was obtained from our radiology PACS system, and post-treatment, we used a histology specimen to measure the size of the tumors. So the pathological complete response was used as an endpoint to compare results to the literature. What we defined a pathological complete response, just like in the literature, was no invasive tumor in the breast and the axilla on pathology post-surgery and treatment. So concordant to literature, most of our patients were women, so that amounted to 97.5% out of 156 patients, and 2.5% were male. 88% of our patients had mastectomies, and 12% of our patients had breast-conserving surgery. Most of our cancers were intraductal cancers. At 94%, 3.8% were lobular cancer. So then we looked at the clinical response, and what we found was 21% of all our patients had a complete pathological response, 31% had a partial response, 31% had stable disease, and 17% had progressive disease. So we used the RECIST criteria to determine the results. Moving on, we decided to look at the tumor biology and to assess the complete pathological response. So we found that 2.9% of our patients who were ER positive and HER2 negative had a complete pathological response, while the ER positive, HER2 positive was 29.4%, 6.7% in the HER2 enriched tumors, and triple negative was 31.9%. Looking at statistical significance, we found that the ER positive and the HER2 negative was statistically significant, just like the triple negative with p-value of less than 0.05. What it basically means was if you were triple negative, you were more likely to be a responder, while if you were ER positive, HER2 negative, you were most likely to be a non-responder to the neoadjuvant chemotherapy. We then decided to compare our study to other similar studies. So we had two studies we compared it to. One was CAN, which was a retrospective analysis in China, and the second one was a meta-analysis by Cortazar. So what we did find was, if we look at our results, the triple negative was essentially similar, 26.2, 33.6, 31.9. The ER positive, HER2 negative was again, we kind of situated between those two studies, 2.9%. CAN had actually 0%. With regards to the ER positive and HER2 positive, were again kind of similar-ish to these studies, But what was interesting to see was our HER2-enriched tumors had a very low response rate at 6.7%. The other two studies had it at 26.2 and 30.2. So we also tried to see whether there was any impact with regards to the treatment gap, basically from the time of onset of diagnosis to the onset of chemotherapy, and from the last date of chemotherapy to surgery, and whether that had any impact on the response rate. We found there was no statistical significance. We also saw that our tumors were much larger compared to that in the literature, which varies in the literature from 9 to 18%. Our patient had 45% of our patients had T3 and T4 tumors. We observed that the larger the tumor, the lower the rate of complete pathological response. That is also concordant with literature. So limitations in this study, we did have a smaller sample size. In our HER2 positive cohort, we had 15 patients. Kian had 44 patients. The Ki-67 was not being done during the time period for this study. Therefore, we could not really subdivide the patient into luminal categories. The RECIST criteria, which usually uses a radiology to measure the treatment response, we used discordant measures. Basically, one was radiology and the second one was histology. That said, to conclude, we can actually say our triple negative tumors, they had the best response to neoadjuvant chemotherapy. The ER positive HER2 negative had the worst response to neoadjuvant chemotherapy at 2.9%. Our HER2-enriched tumors, they had a much lower response compared to the literature, and we believe that adding trastuzumab would definitely help to improve response rates. And if we really had to choose a subset of patients to benefit from trastuzumab, it will be in the HER2-enriched tumors. Thank you.
Thank you, Alvin. Any questions from the floor? You stunned them into silence.
Maybe I can just make one
Georgia,
comment here. So for the hormone receptor negative, HER2 positive, we would really expect a much better response to chemotherapy, even without trastuzumab on board. Do you think that maybe the small sample size, we usually expect about 20% of patients to be HER2 positive, do you think that might have impacted?
So the one thing that we did look was, number one, was our tumor size in that subset of a patient, was it much larger? We actually found it was not. They were actually T2 kind of tumors. So we think that sample size might have played a role, but it might also be the tumor biology itself in our population, which has not really been studied that much. So it's a combination, I guess.
Okay, thanks.
There's one question there from Prof.
We found it that the patients that they have a big tumors, the response rate goes right down. You see, so maybe that's how you can explain that. We see two types of patients in Johannesburg in private.
Sure.
Ones that they come refer when they have a biopsy following like a mammography and it's small tumors. You get the 60% PCR rate on the. But the patients that they present probably in the government sector, the number of the loco-regional disease is much higher. And then on our analysis, statistically goes right down the PCR rate on those patients for everything. For the HER2 positive, with or without trastuzumab, with everything. For triple negative, for luminal tumors also. Yeah. So the sample, to me, still the sample size and the glands, they play a big role on the independently of the biology and all the other fancy stuff. Yeah.
Sure. Thanks, Prof.
I mean, that's very true what you're saying there, but the thing is, if that was true in this study, we would have seen lower rates in all the other groups.
Yeah.
But we had this one outlier group. Our patients, for some reason, are not responding like the rest of the world. Why? I don't know.
Which subset is that now?
That's the HER2-enriched patients.
Yeah, maybe. Did you use adriamycin also or not? What did the combination you use?
So we use cyclophosphamide, doxorubicin, and paclitaxel. So that was for 85% of our patient, and additional 9.4% had docetaxel. So that was basically what I think ISO guidelines. Yeah.